Recording. All right, so welcome everybody as you all are coming in from the waiting room. So today we have a jam-packed webinar for mandated reporting in the perinatal space. So we have many different speakers. We have Marge Meyer, Katie Leffel, Shab Koda, Lindsay Barron, and Kayla Penko. And I'm going to quickly go through a few housekeeping items. For this webinar, we're asking people to use the chat to ask a question. Everybody should be muted upon joining the meeting. So if you wish to ask a question verbally during the Q&A, you feel free to unmute yourself at that point. We also do have some automatic captions, so just click on the show captions option located in your navigation bar. And also, prior to leaving the webinar, please complete the evaluation, which I will be adding into the chat via a link. Acknowledgements, we want to acknowledge that as our AIM grant is funded by HRSA, so please know that everything that is in this webinar does not necessarily represent the official views of HRSA, HHS, or the US government. And we have no disclosures. So at this point, I'm going to turn this over to Marge to start with.
Thank you guys, and I'm going to be quick because we have like a lot more content than we have time today. But I just want to set the big picture stage and why this is so important is that all of us together and collectively are super worried about the health of both the parents and the kids. And in this setting, and for the purposes of this talk, we're really talking about newborns. Because we're really focused in on this very difficult time of towards the end of pregnancy and the development of the newborn and making sure that we are being clear and unbiased in our approach to both the parent and the child and to support them as a family. Basically, our understanding of substance use disorders and treatment has really evolved over time. Similarly, none of us wants to feel that we missed an opportunity to intervene to prevent abuse and neglect. And I will just preface this now is that prevention is very difficult from identification. And as we go through this talk, to think carefully, because I believe most of our structure is around identification and reporting, not so much prevention. We're going to talk about the indications for mandatory reporting because there's just a lot of stuff out there. And at the end of the day, to emphasize that prevention is not particularly helpful. So just reporting parent substance abuse to try and prevent something is actually not an indication for reporting, but we're going to work through that all together. Next slide, please. So I want to remind you that it's quite well agreed from the American Society of Addiction Medicine, the American, there's a typo in there, College of OBGYN, and the American Academy of Pediatrics. Everybody agrees that the evidence of substance use should not be used to implement sanctions on parents, especially child removal, and that other risk factors or harms need to be assessed and identified. And there is objective evidence of abuse, neglect, or other danger to the child, which I will tell you now is very difficult. That's a very high bar and is basically impossible in utero. ACOG recommends that clinicians oppose coercive screening, testing, or treatment, and emphasizes that a positive drug test alone is not diagnostic of a substance use disorder or its severity. Next slide, please. The American Academy of Pediatrics echoes this, is that a CPS report should be considered when the mother or the parent has not received or been adherent to treatment for opioid use disorder, when there's concern for or evidence of polysubstance use during pregnancy, or when there's a concern for infant safety. but not based on a screen alone. And ASIM further recommends that toxicology testing should be obtained only after informed written consent outside emergencies and should be used to treat the mom or the parent and or the newborn. Next slide, please. So this is a paper that was published not too long, is that to remind people that reporting before documented child maltreatment, and again, this by definition can't occur until the baby's on the outside, does not prevent maltreatment and it causes harm. And I'll let you read this study yourself. But basically, this just again hones in on the fact that we are not very effective at preventing maltreatment as well intentioned as we all are. And that attempt at prevention can absolutely cause inadvertent harms and to be cognizant of that. Next slide, please. This goes to Katie, but I am going to mention because I got it in my inbox just yesterday. There's a draft new policy about drug testing in pregnancy that was co-written by the American Society of Addiction Medicine and ACOG. So that'll be distributed as soon as it gets published. It's going out for public comment soon. So now I'm going to turn it over to Katie Leffel.
Hi, so I'm just going to really quickly go through a couple of slides around some data here. And this is maternal mortality. So this is death in the period of pregnancy or the year postpartum. And so this is a specific kind of data. And then there's another slide that talks about other substances. So this is looking at 1 year of reviews recently for our panel. And we had this situation where we just were really able to note that we had 6 people who died directly related to their substance use. 2 looked stable in pregnancy on their substance use treatment. 2 were unstable. Everybody kind of was aware of the situation, what was happening. And then 2 people who died had no indication that they had substance use, clearly didn't disclose, no diagnosis and no awareness. So I use this data to really just keep that awareness alive for people that we don't know when we're looking at somebody across our table or in a bed that what their substance use might be, because they very well may not be disclosing because of that intense stigma around substance use in pregnancy and mothering. So and then we just see year after year, we review deaths related to substance use with involvement and or directly causing death. And most of that happens in that postpartum period after they would have left obstetrical care. So we really need to think about what are we not seeing? We need to think about our own biases, constantly trying to be destigmatizing our language and our approach to our patients. And then we just need to be really universal about letting them know about supports, because you don't know when you're sitting across from someone what their substance use reality might be. And we have a lack of data in general, but we do have some data about opioid overdoses, both prevented opioid overdoses and death, and sort of some of the circumstances surrounding those. As part of an NIH study, they're going to give us back some of our data in Vermont. So we'll know a little bit more about that piece as well. Next slide, please. So this is just some other sources of data. On the left, you're going to see this is our CAPTA reporting, which is at time of birth with when substance use is identified. And those are the substances and the percentages. And this is just for the 6 months since 2026 started. And you see that MOUD treatment and nicotine and cannabis are those really highly reported rates. And alcohol, interestingly, is 2.7% here. And on the right, you're seeing some PRAMS data, which is our surveillance reporting for mothers in that year postpartum who have had a live birth, and it's anonymous. And you see that 3rd trimester alcohol use is actually pretty prevalent. And I point that out because we know we're missing people, and we know that people aren't disclosing. And the most substance use that's reported around alcohol in that postpartum period is actually college educated, privately insured, older birthing people. So again, just to really emphasize, we don't know when we're sitting across from someone what their substance use really looks like. So we really need to make sure that we're offering resources, because reporting them to child welfare is one piece of the picture that may have to happen, but we're all responsible for making sure they get supports. Can you go to the next slide, please? So that's why we talk about mandated supporting, right? And of that CAPTA data that I showed you, which is identified people with substance use at birth, so people that have disclosed their substance use, only 35% of them were engaged in services prior to delivery, community services, which should be 100%. These are people we already know about with substance use disorder. So that feels like a piece of data that we really need to take into our planning with patients in that prenatal period. And then connecting people with primary care, substance use treatments, mental health, nurse home visiting, recovery coaching, community resources, all of that good stuff to support a family well into that postpartum period. Next slide, please. And this last slide is pretty busy. This is just a list of resources. These are available all across the state in various configurations. It's really about knowing the resources in your community. And when you get these slides, all of these are links to, so you can click on any of these slides or any of these resources and understand sort of how to access them. But it's really about getting to know the resources in your community and connecting people prenatally and just making sure people are aware universally so they aren't having to figure it out on their own afterwards. And I think I pass it over to Shab next.
Hi, everybody. Thanks for having me. My name is Shab Koda, and I'm a training and coaching specialist with the Vermont Child Welfare Training Partnership. Some of you may be familiar with our organization. I'll give you a brief overview. We are located within the University of Vermont. We're a small program, and we are federally funded through Title IV-E funds. And our main mission is to train and support the child welfare workforce within the state of Vermont. And that looks like there's a couple of ways that we do that. One is through higher education. And so there are Title IV-E students who access either the bachelor's program or the master's program and then work for the state of Vermont in their child welfare family services division and are able to get education through the university and essentially pay off the cost of that education through working for the state. And then the other part of our program consists of a number of training specialists like myself, and we train the new hires as well as the existing and ongoing established staff in their roles and provide support and coaching to the division as they are enacting their mission of supporting families and supporting child safety. So we also provide training and coaching for resource foster and kin parents. And so we have both like online asynchronous trainings as well as in-person trainings for both the workforce and the caregivers. So we have a really active website with lots and lots of resources. We also have a podcast that has lots of really great episodes related to child welfare and supporting families in the community. So really encourage you to check out our website and our podcast. Lots of great resources on the site. Next slide. So I'm here to talk with you today about an update to our mandated reporter training. The existing training has been in place for many years. And Lindsay can talk a little bit more about the impetus for the update, but essentially there was a request for us to start to move towards being more in line with national trends at this time in terms of mandated reporting and the concept of mandated of supporting versus reporting. At this time, Vermont statute remains the same. So there has not been any change to the laws, which make it so that it's a little challenging to try to make any huge sweeping changes to the mandated reporting practices or policies. And we don't have big changes in infrastructure in place that would allow us to really shift the mandated reporting practices. Having said that, we do want to try to be more up to date with the practices that we are supporting mandated reporters to be utilizing. And so in line with that, we have updated our training. It's about 90 minutes long, which is, I think, shorter than the current training. It's about to launch, so it's not quite live, but hopefully by the end of this week, it will be live. It can be accessed through the Child Welfare Training Partnership website. And our website is the only place that will be hosting the training and will be issuing certificates of completion. The certificates will include the date of completion as well as the sort of the hours, right? So it'll be like 90 minutes worth of course completion will be included on the certificate. So people who need that, you'll have that information on the certificate. Um, the components of the updated training are largely the same because the laws and the policies have not changed. So what we've tried to do is really simplify the messaging and be very, very clear about what exactly the laws require reporters to do. And the key elements that we emphasize are the need for reasonable suspicion and the requirement to report within 24 hours. So essentially, as soon as someone has information that leads them to believe, reasonably believe, that child abuse or neglect has occurred or is about to occur, there's a really short time frame within which a report has to be made to the department. We talk a little bit about what it means to have reasonable suspicion. And I think part of that lends itself to the shift in messaging tone. Previously, you probably would be familiar with this concept or this catchphrase, when in doubt, make a report. And for a long time, that has been the standard approach for mandated reporters. The division advised and supported people, go ahead and call our intake number, talk to us about your concerns, talk it through with us, make a report. We'll decide whether it needs to be accepted or not. The truth is that while the division still will be making the final decision about whether information should be accepted for a response, it really is incumbent on the community and the reporters to be thinking as critically as possible about whether the information you have actually is reasonable for child abuse or neglect. Is it factual? We shouldn't be making reports based on hunches. We shouldn't be making reports because we get a weird feeling. We shouldn't be making reports because we're uncomfortable, we're worried about our own liability, or our potential values, personal values, or bias might be coming into play. These are all factors that we have to be really attentive to and check ourselves for. Ultimately, because we want to make sure that when families come into contact with the system, it's it's necessary and that the system is able to intervene in a way that ultimately promotes child safety and minimizes stigma, as was being discussed earlier, or unnecessary involvement. So the messaging has shifted from when in doubt, make a report to think critically and report responsibly. Consult with colleagues as soon as you're able and get another opinion on, hey, am I reading this right? What are your thoughts here? What does our organization typically do? Check yourself for bias and personal values. Check yourself for any possible lack of knowledge about a family's cultural practices or parenting practices. These are the processes of critical thinking that reporters need to responsibly engage in to make sure that the department is well equipped to respond to real child safety issues and not generalized concerns or hopes for services, et cetera. So that's sort of the general idea of the revised training. Hopefully that messaging will be clear and feel pretty accessible. The intended audience is anyone in Vermont who is considered a mandated reporter. And again, accessing the training will be through the VT CWTP website, which I think if you click the QR code, it should take you there. Happy to answer questions now or later if there are any. Thanks.
Thanks, Shab. And yeah, we'll do questions all at the end, but thank you very much for that info. And yes, that once you get the PDF, you'll be able to have that QR code and a clickable URL. So now I would like to welcome Lindsay Barron, and please do your own introduction, Lindsay.
Hi, everyone. My name is Lindsay Barron. I'm the Director of Policy and Planning for the Family Services Division within the Department of Children and Families. For the sake of time, I won't add too much about what Shab just shared about our updates to the mandated reporter training. I will just acknowledge that it's been a really exciting project to partner with Shab on. And I think the timing is really great because while our statutes have not changed yet, there is lots of opportunity coming up in the future where they will likely be revised based on a multidisciplinary sort of team of individuals and stakeholders. And so what I'll just flag for the group for awareness is that at the conclusion of this legislative session, Act 108 passed, which creates a child abuse and neglect reporting working group. And so over the course of the next year and a half, there will be a group of individuals coming together to look at statutes, look at trainings, look at definitions, and make recommendations back to the legislature. And so we already have a website up and running and live on our public site to support this work. And then we will also have some advisory committees happening behind the scenes to support individuals who would like to participate and have their voices heard, who may not be named individuals on that working group. And so keep that in mind. I will drop my contact information in the chat if you would like to learn more about that or participate. One of the most frequently asked questions, I would say, that we receive related to acceptance criteria is what are the definitions or how are intakes involving substance use screened? And so once a child is born, there are many different definitions that could be screened depending if physical abuse occurs or if neglect is occurring. But the most obvious one explicitly named in statute is risk of harm. And that is because it explicitly names failing to provide supervision or care related to substance use or related to situations in which drugs, alcohol, or other paraphernalia are accessible to children. And so I just wanted to have this definition up on the first slide. We can go to the next one. And there's a few data slides that come next, and I'm going to absolutely fly through these. What I want to call your attention to on this slide is the column for birth through 12 months. This gives a glimpse in time into the intakes that have been accepted for ages. This goes through birth through 5 years old, but again, in particular, the column for infants through 12 months. And so this goes back a few years, giving you a sense of how that varies year to year. Next slide, please. And this next slide is substantiated abuse. And again, I would point out the blue bar that is speaking to birth through 12 months. And so in this data, I think the important piece to note is that one of the reasons these numbers may be so low is because Vermont has a differential response system. And so most intakes involving either prenatal reports or reports about an infant where substance use and supervision issues are a concern, those are often likely to be accepted as assessments, which are more focused on support, connection to referrals, family network building, rather than determining whether abuse or neglect occurred, reaching that determination at the end of a child safety intervention. Next slide, please. So in this slide, because we lack a great database to capture information for us, annually we do a survey to all 12 of our district offices, inquiring case by case how many cases are open and how many families we are serving where children are in custody, where it opened due to substance use issues. We've been conducting this survey for the last 11 years, so we have some data over time at this point. What feels really noteworthy, just to name, is that in 2024, 2024, we had the highest percentage of children ages 0 to 5 in custody due to substance use issues. That was at about 71.5% back in 2024. And then for opioids in particular, that was 56.1%. Those numbers have since decreased, thankfully. And now it is about 60. Let me go to the next slide. Sorry. And so these numbers have come down. This is a glimpse. Actually, if we could toggle back and forth, that might actually be helpful. And so on the prior slide for 2025, it was roughly 33 impacted children. And then if you toggle over to the next slide, it's about 15 children specific to opioids. And so we know that reflects trends happening in the community, trends around use. And it also shows shifts in time, as you'll see throughout the years, of just how impactful that was on our system about a decade ago. And then next slide, please. And this is really where I want to spend the bulk of the time, just sharing a bit of information about, from the perspective of the department and specifically within the Family Services Division, what we are thinking about, how we are working with families, and the types of information that we are either gathering, using to inform our assessment, and using to sort of determine next steps. And so when we talk about parental substance use, the goal is not to just simply identify whether substances are being used. The goal is to understand how that use is impacting child safety, one's ability to parent and caregive, and the overall family's ability to meet the child's needs to be safe. And so that's why it really goes beyond like a singular question or a screening tool. We're looking at caregiver patterns of use, whether substances are being procured or sold from the home, the impact it's having on parenting, and generally the safety of the home environment and what is accessible to children, the vulnerabilities of both the infant and the parent, the overall family support network and their ability and willingness to intervene and provide, caretaking while one might be using, and the caregiver's own understanding of the situation, their use and their needs. And so we know that substance use exists on a spectrum. We also know that can change over time. And so we look at a number of factors as to whether substances are being combined, and also what does the day-to-day look like? And so while this may vary for an infant, for children generally, we're looking at like, are the basic needs being met? Is the child attending school? Is the infant or child attending all of their medical appointments or dental appointments? Is there adequate food and nutrients in the home? What's the overall condition of the home? And is the caregiver able to respond consistently to the needs? We also look at other risk factors and vulnerabilities that might increase or decrease risk. And so substance use is one consideration, but is that occurring at the same time as significant mental health concerns? Is that occurring at the same time where one is experiencing domestic violence? Is that occurring on top of housing insecurity or food insecurity, or are others coming and going from home? And so, who is living there? Who within the adults in the home are using substances? Is paraphernalia accessible to kids? Are there any concerns about drug trafficking or human trafficking, violence, other illegal activity that is a factor? And also when it comes to procurement, are the children present whenever the substances are being purchased? Are they riding in the vehicles? Are they being brought into unsafe environments? And so on. I could go on and on and on as far as the considerations and what we contemplate and consider. And so at the same time, one of the big pieces that we are looking at is protective factors and family network and those who can come in and support the family. And so is there another sober protective caregiver or multiple caregivers who can provide support? Are family members or other natural supports, neighbors, willing to step in when needed? Are they willing to intervene? does the parent recognize the concerns? Are they able to tag in someone as part of a plan? Are they engaged in treatment? Do they have peer recovery supports, counseling, coaching, or other recovery-oriented services? And really, this comprehensive look is what allows us to safety plan where possible. It is not an immediate jump to court intervention. That's really the last step, or the last consideration whenever we are providing these assessments. And so a piece of our work as well involves making connections to community referrals. That might be children's integrated services, nurse home visiting programs, intensive-based services, or intensive family-based services, which we refer to as IFBS. And then another huge partner in our work with families is our partnership with Lund through the Regional Partnership Program. And so what that is that co-located within each of our 12 district offices, we either have a full-time or a part-time Lund partner who is integrated into the front-end teams within our districts. And so they are commencing cases with our staff. They are helping to assess for substance use disorder. They're helping to really get folks connected into treatment. It's a voluntary program, and so none of it is coming with obligation, but it's really designed to increase access to treatment and support and increase or sort of preserve permanency. And so some of the activities, again, very briefly, that they do is screen for substance use. They use the UNCOPE screening tool for that, address any barriers to engaging in treatment. They also make referrals and support, and they provide consultation to our staff who might not all be experts in substance use disorder. And then they also work with the local system of care to identify gaps and make recommendations also for improvements in the community. I think that is all for me.
Thanks, Lindsay. All right, so I wanted to bring this back around to like, why did we start this work to begin with for at least our Vermont AIM team and collaborating with these different partners? And as we all know, the current bundle that we are in is the care of pregnant and postpartum people with substance use disorder. And there specifically, this comes right out of the change packet on the recommendations on work to be done during this rollout of the bundle. So develop clear educational resources that address common myths about institutional and state policies for child protection reporting, and train clinicians in the actual requirements for reporting SUD and correct misconceptions to prevent unnecessary reporting. So this is really important to our team to dive into, and we were able to understand what other work was being done already. That's when we got connected with Shab and her team, learning about the mandated reporting training coming, being updated, and that's why we also had like paused and rescheduled this webinar, because they were deep into that work. So we wanted to try to align as much as possible to also show you that, like we stated before, it takes a village to prevent child maltreatment and safety, and we all come at it from different angles, but we want to be as transparent as possible amongst the partnerships that we have. So next slide, please. So the way that we decided to go about this is learning that the current mandated reporting training touches on a lot of different subjects, and being able to condense it down to 90 minutes is a feat. I was able to see one of the first renditions of it, and that is quite impressive that it's down to 90 minutes. But one thing that it doesn't go into deep a dive on is in the perinatal space, because it is gray and it is a little nuanced. So that's where we really focused our energy, because that's also our population that we're working with. So for the Vermont AIM team and with our PQC colleagues, we created these two different resources. So the purple one is a physical booklet, and we call it our mini guide for guidance for healthcare professionals on mandated reporting in the perinatal space. And then to the right is a rack card that is more patient facing, and just trying to bring transparency to that we are mandated reporters. I realized I didn't do an image on the back, but on the back kind of says like what we are mandated to report. And then another section on like what we may need to report, because again, it's super nuanced. We all have been in this area for a while. It's gray, but we wanted to try as much as we could to bring transparency to it and a little clarification. So next slide, please. Um, I just wanted to note this was a multiple perspective approach. Lots of different people had eyes on this. The draft must have had, I don't even know at this point, 20 different versions of it. It's been worked on. It's been a labor of love, no pun intended, for many, many months, with lots of voices to try to get to some clarity. Next slide. So we're going to go through for the rest of this webinar. I'm going to try not to go so fast that we don't comprehend and like let it sink in, but I want to leave time for questions as well, but really showing you what parts of what is included in the mini guide. And I want to be completely transparent that the goal is to provide healthcare professionals who work with pregnant and postpartum people with the knowledge of Vermont statute and their legal requirements to their role as a mandated reporter, very specifically looking at the perinatal space as related to substance use. But this is not to swing the pendulum and to tell you you should not report to Family Services Hotline when appropriate. I want to make that really clear. This is guidance and for us to kind of reset on things maybe we didn't know before. I personally had been a nurse already for 12 years before I looked into this, and I learned a ton when I actually looked at the statutes and the research. So trying to just share some of that perspective with you all today. Next slide, please. So this will be the first page, and then there's a content list, and we're gonna, like I said, we're gonna pop through some of these really quickly, and we'll dive in a little bit deeper to some of these sections. Next slide. So this PAUSE acronym comes right from the mandated reporting training that Shab was speaking to. And I think it's really important that we do the things as she spoke to. We pause, we provide resources if that is the main area of concern. We analyze the facts, we uncover our root beliefs, we seek a second opinion, and then we empower families. So I really love this acronym, and you'll learn more about it when you hopefully do the mandated reporting training. Plug in for that. There is the QR code in our booklet to get to that website, as well as a clickable link. And also, this is with a caveat of knowing that limitation of within 24 hours of being aware of the situation. This is not meant to pause and sit on for days to weeks. This is to pause in the moment and not have knee-jerk reactions. And that's really our big focus, is not having knee-jerk reaction to, oh, there was a positive UDS, and then I need to make a report. Like, this is really to slow down and bring others to the table, but still within a reasonable amount of time. Next slide, please. So we really want to start it by looking at state law and giving people the resources to find these. Like I said, I had never looked at this before in my profession. And there's two different links and QR codes here. One is the Vermont mandated reporting list. So it lists out all the professionals in Vermont that fall under this mandated reporter guidelines. And I know I've heard from colleagues before that they didn't realize they were a mandated reporter. So I think it's a really good refresher. And like I said, this is for easy clickable use, and we're not going to go into all of the jargon. And then the second one is the actual Vermont statutes, which is Title 33, Chapter 49. But this section specifically looks at mandated reporting requirements, definitions of child abuse and neglect, and procedures for investigation and assessments. So that is what's in the Vermont law. And then as like a subset, GCF Family Services Division takes those and then has their own internal policies of how they construe their work. So it's related, but kind of like two different buckets. Okay, we'll go to the next slide. So what the rest of this guide goes into is I took the actual legislature and and put it in here to look at and to really try to like tease it apart and kind of just slow it down for people. So this first section looks at what are the Vermont laws for obtaining toxicology or drug testing when there is known or suspected substance use in pregnancy or following delivery. And these bullets come right out of the statutes. So a urine drug test on a pregnant or postpartum person with a history of substance use is not required by law. That might be news for some of you. If toxicology testing is needed for medical care, the recommendations are that providers should discuss the risks and benefits of testing with the patient and get informed consent prior to sending any test. And I know we've shared that messaging before with some of our webinars, but I just wanted to, tie it back to the Vermont statutes. Toxicology testing on a newborn is also not required by law. An informed parental consent should be obtained if testing is required for a medical indication. And then substance use in pregnancy or positive toxicology testing of a birthing person or newborn does not require a mandated report to be made. So to make things cloudy, because that's what we like to do sometimes, while that is not part of statute and is not required as a mandated reporter to report, DCF policy, so their internal policies would allow them to accept the report for a family assessment. So we have statute and then we have policies on the FSD side to be able to look into, open an assessment and look at a case. So those are different, and we just wanted to call those two things out. On this page as well is an evidence-based article on neonatal that we've referenced. So we tried as much as we could in this guide to reference back to the sources to give you those evidence-based protocols and guidelines. Next slide, please. So the next thing to dive into is, does making a report to DCF and the Family Services Division help families affected by substance use access community supports? So as Lindsay stated, there are certain resources that they can connect to, but it's the primary role of FSD is to keep children safe from abuse and neglect. And their primary goal is not to be a community referral source. Their purpose is to intervene when there is already child abuse and neglect. So simply making a call to the hotline does not guarantee families will be connected to resources. So that's where we really need to, in the clinical space, be able to identify needs and connect patients and families as quickly as possible to resources so it doesn't become an issue of child safety. So that's something we really wanted to hone in on. And the next slide, I'm not going to read it verbatim because we'll have this to you in slides and the actual PDF of the booklet following this webinar. Vermont law includes a risk of harm statute covering substance use. So Lindsay spoke to this. The one thing I just wanted to highlight is no current law mandates reporting during pregnancy. So that was kind of news to me. But it is best practice to provide the pregnant patient with education, referrals, treatment, and resources to address their substance use. So again, this criteria is relevant after birth, but not during pregnancy when it ties back to the risk of harm statute. The newborn has to be on the outside. All right, next slide, please. We thought it was important. We could have done a whole, this was originally supposed to be a one-pager. It did not turn into a one-pager. And then I really had to figure out how to scale it back so this also didn't become a chapter book. But we wanted to make sure that we did touch upon documentation, as in the clinical realm, documentation is obviously a large percentage of our jobs. So just to reinforce that documentation is not the same as reporting to DCF. So documentation remains a key component for clinical care, and providers, clinicians of any type should feel confident in documenting their concerns in a factual basis in the medical record with the goal of collaborating and information sharing with other members of the team. That way, if down the road patterns are becoming evident or there's an escalation of needs that do then point to the potential risk for child safety and neglect, then that would constitute taking that next step. But we just want to make sure that people really think about their documentation, thinking about the words they use and being super factual and checking their biases prior to adding something to either parental charts or newborn charts. And it's really the collaborative effort between all the different types of providers, OB, mental and behavioral health, substance use, community partners, in the pediatric medical homes to support families throughout this continuum. A plug, because we always have to do a plug for it, the Family Care Plan is one patient-centered tool to connect clinical and community providers together, and that's where this work kind of comes full circle as well. Next slide, please. So this next section, we kind of did a true or false. And these are some of the most common myths, I would say, that we've had people, give us as questions, or I've seen in the literature, or I've experienced it in um, my own work and those of us who were working on this. So this first one is I have to report substance use in the third trimester or the last 30 days of pregnancy. And this is actually false. There is nothing in the statutes for mandated reporting in the state of Vermont that say this needs to occur. The practice was originally intended to enable FSD staff to identify and support pregnant people across and access coordinated services and create plans for safer parenting. In the ideal world, that would decrease emergency custody cases. But what we've, come to see, nationally with research is it's not actually showing to be helpful, and making a report prior to birth without the patient's knowledge and consent could actually violate HIPAA by disclosing the protected health information of the birth parent. So that is the first thing that we wanted to clarify. Next slide. So I have to report a positive drug test on either birth parent or newborn at time of birth hospitalization. This is also false. And as we already spoke to in the mandates, that substance use in pregnancy alone does not indicate the need for a report in Vermont. The other concerns must also exist. So that we just kind of we break that out into two different sections on this page to just dive into that a little bit deeper. And then next slide. And this was the second one. I have no real suspicion of abuse or neglect, but I could lose my license if I don't make a defensive report. And in all reality, prosecution of mandated reporters for failing to make a report is exceptionally rare in any state, and Vermont law does not criminalize substance use in pregnancy. So you're covered in that regard. You do not need to make a mandated report based on substance use alone. Next slide. When a family has a family care plan, which is currently called a plan of safe care, or needs to have a CAPTA notification, this is another indication for reporting, and that is also not true. Katie and I and others, Dr. Shepard and Lindsay was on this work too, when we were revising the CAPTA process, is we were really trying to tease apart that the CAPTA de-identified notification is different than a mandated report, and that is also different than a family care plan. So really trying to tease those things apart. While they could be related, or families could need all three of these things eventually at some point during their perinatal experience, they are not they're not all ands, and they don't always overlap. So just trying to bring that clarification. Next slide, please. So then the last section of this guidebook is doing some case study examples. And I will say this does not cover all. We chose 3 and we tried to make them different and kind of what we think the most likely clarifications that were needed. And the hardest part about this, we've had a lot of feedback on this section. The hardest part is to read the case study as is and only that, and to not bring in the what ifs, or this happened to me before, or I knew a family with X, Y, and Z. It's really looking at the information in front of you and whether you would automatically make a mandated report, or you would pause and think about other actions first. So I'm gonna go through these just to show you what's in there, and then I'm trying to go through quick so we can hopefully have a minute or two for questions. But this first one looks at your patient at 36 weeks gestation discloses to you that they have been using alcohol throughout pregnancy, and your options would be to report or to pause. And this one we would recommend that you would pause. Your action items would be thanking the patient for sharing with you, providing a brief intervention, education, and initiate or refer to treatment, and provide specific ways to access treatment. So that SBIRT model that we've talked about before. And then provide the patient with reassurance that you can provide support and resources. And at this point, at the 36 weeks pregnant disclosure of substance use by Vermont law, you are not required to make a report based on this alone. So next slide. So the second one is at a different point of the continuum. Your patient arrives in active labor with no prenatal care and marks on their arms. So that's it. That's all you get for information. So we want to make sure that, people don't put in their own biases or their assumptions, and they pause. And that's when the recommendations would come in to provide a paper-based or verbal screening tool for substance use disorder. You are still not required to do a urine drug screen. It's not required by law or recommended in any of the like the recommendations that Marge shared earlier, only if it informs medical decision making for the parent or the newborn, and that you've talked and been transparent with the patient that you are concerned about substance use and that you would recommend a urine drug screen so better and more informative care could happen for you and your newborn and get the patient's consent. Provide appropriate interventions and treatment options. We want to put a plug in if opiate use disorder is what is being disclosed, that medications for opiate use disorder can be initiated inpatient. And if you don't have inpatient protocols, you can always utilize your emergency department colleagues for initiation. And then having that continuum of communication with the newborn care provider. But for this case as well, unless there's active safety concerns with the newborn occurring during hospitalization, this case would also not meet criteria for making a report based on this and this alone. Okay, let's go to the next slide just for sake of time. So this third one, postpartum. Your patient is 2 days postpartum and has left the unit 6 times in the past 8 hours. They have a recent history of active opioid use and have not been engaging in prenatal care or other types of recovery treatment. Multiple times they have returned to the unit unable to have a conversation with you without nodding off, is slurring their words, and has not initiated any newborn care without reminders and assistance. For this one, we would say report. There's still other action items, obviously, that need to occur, but there is concerns for newborn care and safety as evidenced by not being able to hold a conversation, leaving the unit, not being able to provide newborn care without multiple reminders and assistance. So it's not the fact that there's suspected substance use in this case, it's the suspected substance use plus these other factors that bring it to the level of a report. But as we say in the actions, we should still be doing the same things of drawing a team together, having a conversation with the parent, expressing concerns and offering screening and treatment options, being transparent that there is active concerns, and that there will be a mandated report that will happen, and then providing reassurance that there are treatment options available and the team will support them in accessing these resources. All right, next slide. So to sum it all up, we gave you guys a lot of content today, and we won't get to dive into it as much as we had hoped, but these are like the take-home messages that substance use alone is not indicative of mandated reporting during pregnancy or following the birth without the presence of other factors that risk harm to the newborn. So this is postpartum. Substance use in pregnancy is not illegal or defined as child abuse in Vermont. And I want to be really clear, each state is different. So this is Vermont. I know we have bordering states with different guidelines. So this is very specifically Vermont that we dove into. Birthing people should be supported in disclosing substance use during pregnancy so they can receive the supports they need and hopefully desire. We talked a lot about toxicology, and it should only be used if it changes clinical management, and informed consent should be obtained. And then if concerns are noted, connect families with identified services and determine a follow-up plan. If safety concerns are reasonably expected, it is your responsibility to make a DCF hotline report. So that was to sum it all up. And then our last page is different resources, so different webinars that we've hosted. There is some online free modules regarding child welfare reporting training for healthcare professionals. We had Dr. Terpling come last year for those who saw his presentation. And those first 2 sections on the Learn More page reference that. We have the Vermont Department of Health resources, the One More Conversation materials, our updated CAPTA process, and then soon to be our updated family care plan resources will be there. There's a great Academy of Perinatal Harm Reduction resource here at the bottom. And then on the right is the different references we used to dive into this. Can you go into the next slide, Sam? So we currently have these in print and e-copy form for the two resources that I shared. You can email Samantha for the hard copies. Just put .org at the end of UVM Health. It just got cut off for some reason. And then if you want e-copies, please email me. But we will send both of those with this recording link and with the slides. And then next slide. Do you want to finish this then?
This is just to remember that regardless of whether we report to DCF, we are all responsible for addressing our bias, offering supports to our patients, and helping connect to resources, because we don't know who's using substances, and so we can't use our need to report as the guide. Thanks.
All right, and I think we just gave you a lot of information in a short period of time, but we have a couple minutes if there's any burning questions. People are come off mute. I will try to go back into the chat and see if there was anything specific. I think it was just us giving more resources in the chat. Okay. You guys have us for 4 minutes. Is there any questions, any just thoughts in general?
When the new ASAM drug testing guidelines are sent around, I'll send them around. I will tell you, it's a super long document, and it has to do with everybody, because actually the issue of drug testing is not just a pregnancy thing, believe it or not. So anyway, but I'll send that document around once it gets finalized.
Great, thanks, Marge. And I see a question in the chat. Who conducts the family care plan? A new midwife to UVM. Well, welcome. Every region is going to handle the family care plan a little bit differently. So I can't give you a clear-cut answer, but the ideal is that screening/disclosure happens in the OB office, and then each OB office is deciding either whether someone internally will start the family care plan, initiate it with a patient, or if there'll be a referral to home health to Strong Families Vermont, and they will start it. Or if there's a third entity. We are currently starting our pilots and looking at 3 different tracks to map those out. So for the UVM group, we do not have that figured out quite yet, but more to come in the next several months.
One of the key pieces with the family care plan and kind of all of our messaging is that the earlier you have the conversation, the earlier connect to resources, and then you want those resources to be something that's going to be supportive for that full year postpartum. So the more we can get families connected to a resource that's going to be meeting them where they're at for that full year, because we know people resume use even if they are able to cut back or cut it out during pregnancy. It oftentimes comes back postpartum. So we really want to emphasize that as a really important piece of this.
Yeah, I'll talk to you about how we're going to manage here at UVM, but I just want people to know that while we're starting this with a fairly focused, the family care plan with a very focused population, I think all of us can agree that pretty much every family should have a family care plan and a very deep dive into the resources that they need for support, of course, now more than ever. And so once we get the pilots done, we're actually hoping to expand this to as many pregnant people as possible.
Great point, Marge. Are there really no questions? Because this is shocking.
We just did a great job.
This is Andrea. I have a question.
Great.
I think a really helpful resource, if you guys don't already have one, would be sending out a policy for perinatal and neonatal toxicology screening. Currently, I don't. So at our facility, we have our nurses use the five Ps, and then if they get a positive response to any question, how our provider orders are written are to go ahead and send a urine toxicology test.
Okay. We can work on that with you for sure.
That would be awesome. Thanks.
Yeah, definitely. Thanks for
Yeah,
bringing
and
that.
one of the things that we had talked about, I don't know who else out there, but I do know that some years ago we did a deep dive into routine drug testing. Some people were doing it on every prenatal visit. And to make a long story short, if you feel like you're not doing informed consent, treatment specific indicated drug testing, just shoot one of us some message. I think the ASAM guidelines will help you. You can look at ACOG actually has some good guidance for that. And we can certainly provide you with guidance if you feel that you need to relook at your drug testing. We redid our policy. I'll be honest with you, I haven't read it for a bit, but we could probably send you a copy of ours.
Great. Well, we see the time. Thank you all so much. If you have follow-up questions, feel free to reach out and we'll get the slides and recording to you within the next week. Thank you for your time. Thanks, Lindsay, and
For
thanks, Shab,
everybody.
for joining us.